Dr. Gerardi, many of you who know personally and by reputation, serves as the Wayne Eisen Professor and Chair for Cardiothoracic Surgery at Cornell and New York Hospital. He went to college at Harvard, earned his medical degree at Cornell, where he trained in general surgery and cardiothoracic surgery, had a short stint at Baylor, after which he returned to Cornell and has been there for the rest of his career. He also holds the record, as many of you know, of being the busiest open heart surgeon in the state of New York for the past 25 years. So no small feat. If that was not enough, Dr. Gerardi's published over 300 peer-reviewed manuscripts, serves as a feature editor for JTCVS. He has had significant leadership presence for the AATS, including program chair, treasurer-elect, and now treasurer. He has won several awards from the Marfan Foundation and AHA over his career. We are absolutely fortunate to have Dr. Gerardi here. I remember my time when I was a medical student, fourth-year medical student, and I was telling him for the first time last night at Cornell, and I was told this heart surgery business is going to be gone by the time I graduate medical school, and not to bother. But at the same time, all I would hear about in Michelassi's room and Fahey's room was like, oh, you got to go watch Gerardi operate. You got to go watch Gerardi operate. And you know, and that was probably early on in Dr. Gerardi's career. And I think everyone around him knew the leader he was going to become. And so we're fortunate to have Dr. Gerardi. Thank you again for coming. Thank you to the AATS, and thank you, Angie, for putting together a seamless program. So,
thank you.
Thanks.
Thank you, Dr. Sultan, and really thanks to all the faculty and Dr. Morrell for inviting me back to Pittsburgh. As you know, I'm a proud Pittsburgher, and except for the 3 hours on Saturday night in Baltimore, I've been very proud to be a Pittsburgher. What a disappointment is an understatement. But by the same token, it's a real honor to be here back in Pittsburgh and to be giving the Tim Gardner Honoring Our Mentors lecture. Will this go? Yep, you did it. Cool. All right. Well, as is the case, when you give a lecture in somebody's honor, you want to know a little bit more about him. And I think knowing a lot about Tim Gardner, and I've met him multiple times, and I think Dr. Sultan has had a chance to meet him too in his time at Penn. But this is one of the true giants of CT surgery. And, he completed his undergraduate in medical education at Georgetown and then went on to Hopkins to do general surgery and CT surgery. And of course, like many in his era, this was interrupted by the Vietnam War, and he spent 3 years in Thailand at the U.S. Army Medical Corps, and then returned back to Hopkins. And of course, there was no spot for him, so he went into the lab for a few years and then finally came out and completed his training before joining the faculty at Hopkins in '76. And then he was there for almost 20 years before Penn recruited him to be their chief. And he did an amazing job of getting that program going and helping establish its preeminent position in all the training programs and cardiothoracic programs across the world during his time. And then in '05, he moved from Penn over to Christiana in Delaware, and he's been the medical director of their heart and vascular health system since that time. Truly an amazing career, and there are very few people that have held as many positions of importance in our specialty as Tim Gardner. I mean, he's the 82nd president of the ATS. He was also the president of the American Heart Association, and that double is really an unusual combination. Chair of the American Board of Thoracic Surgery, and he continues to be involved in things like CTS-NET, and was awarded the ATS Lifetime Achievement Award in '15. So I really am honored to be giving the Tim Gardner lecture, although I certainly have absolutely no business being in his presence considering what he's accomplished, and that's for sure. Returning to Pittsburgh is always very, very heartwarming for me. I do think it's a pretty city, and irrespective of who's calling it the most livable city or not, I think it's very pretty, particularly from Mount Washington as you look down and you see the inclines going down the hill and you look at the point and the Three Rivers. It is a beautiful city, and your medical center has helped transition this town from what it used to be when I was growing up, which was this. And I think that was supposed to be a color picture, but actually that's the way the sky looked back then. That was the Aliquippa Works, where I was born and grew up in my early years. But UPMC and your other educational institutions here, such as Carnegie Mellon, you've helped transition this city to healthcare, innovation, high tech, and it's been an incredible transition, and glad that it no longer looks like this. Now, obviously, the steel industry is still important here, but nonetheless, it's transitioned well. And just a little background, I grew up and was born in Aliquippa, which sits about 34 miles, as you know, northeast of here, right on the Ohio. It's one of the oldest towns in all of Pennsylvania, dating back to the 1600s, and it got its name from Queen Aliquippa, who you see there meeting with George Washington. She was the head of the Seneca tribe at that time, and that's where Aliquippa got its name. My parents were not college educated, but they understood the importance of getting out of the steel mills and coal mines and moved us over to Swickley when I was about 11. And from there, they had a better educational system, and certainly they understood the importance of that, and it's worked out pretty well for our family since that time. And from there and from college, I went to New York City. This is our campus on the Upper East Side of New York. I've been here since 1985, except for 1 year when I was in Houston. And the New York Hospital is this building here, and this is Cornell Medical College here on York Avenue. It's the second oldest hospital in the United States. It was founded in 1771 on a charter from King George II. We've moved around all over New York City in the last 254 years, but have resided in this spot since the late 1800s when New York Hospital combined with Weill Cornell Medicine. Of course, it wasn't Weill Cornell at that time. Sandy Weill hadn't given $800 million, but now it is Weill Cornell Medical. And it's really a great place to have medical education. Over here on 70th Street is the Hospital for Special Surgery, one of the better orthopedic hospitals in the country. This is Sloan Kettering. And then this little area devoid of big buildings but a lot of trees is Rockefeller University, where the highest concentration of Nobel laureates per capita sits in this little 1 square mile space on York Avenue. We sit right on the East River. This is the Queensboro Bridge connecting Manhattan to Queens, and it's a great place to train, and they've been very supportive throughout my career, and I'm very grateful. When I got back from Houston in '97, we did not have really much of an aortic surgery program. We were just doing type A's and the occasional rupture here and there. And I had spent that year in Houston learning the nuances of aortic surgery and wanted to come back and start a program. And I was very grateful again for the support of the hospital and the department for letting us get this off the ground. Mount Sinai at the time with Dr. Greep was the 800-pound gorilla in aortic surgery in New York, and we wanted to start a program. And so we kind of took on everything from roots to arches to descendings, and eventually evolved into some of the complex operations that we are today. But it took a real institutional investment, and not just the hospital investment, but also the department investments and a personal investment to start collaborations, because aortic surgery is a team sport. Most of cardiothoracic is a team sport, but particularly aortic surgery, where you depend so heavily on your consultants, particularly your critical care colleagues and your colleagues in the Department of Anesthesiology. You have to have all buy-in to get it done. And you can get most of these done pretty well with systems that are okay, but the ultimate challenge, thoracoabdominal aneurysm repair, you cannot do without collaboration in the OR, in the ICU, and throughout the entirety of the stay of the patient. This is a technical, it is a perioperative care challenge, it is an emotional challenge. Thoracoabdominals really get your attention. You probably don't sleep too well the night before when you're thinking of doing an extent 2. And so you get yourself pretty worked up, but for good reason. These are high-risk operations. There's a lot of bad stuff that can happen when you don't have good people helping you do these operations and when you yourself are not focused. So it took us a little bit more time to get this program off the ground, and we were very thoughtful as to how we do it, because the kind of complications that you can have when you do open thoracos can really shut your program down pretty fast. And so you want to make sure that you have everything set before you kind of take this on. I think when we think back of how this was done, I think it is good to know where we came from. And while it is debatable as to who actually did the first thoraco, there were 3 single case reports in the literature around the same time in the early 50s. But what is not debatable is not so much who did it first, but the contribution of Drs. DeBakey and Cooley in this specialty going back into the 50s. As you know, Denton Cooley started his career working for Mike DeBakey at the Methodist Hospital at Baylor. The rest is history as to their falling out and then their subsequent making up as they became more senior members of our specialty. But this was the first case report by DeBakey. It was published in JAMA in '53, and it's pretty amazing to think of what they did in '52 or '53 when they did this case. This is a 45-year-old gentleman who had essentially an extent 5 aneurysm from the lower chest down to the viscerals. They used a clamp and sew technique. There were no adjuncts at that time, right? The heart and lung machine was just kind of coming around. And there were no Dacron grafts, so a homograph was used to replace the aorta with a 45-minute cross-clamp time. And as per the case with DeBakey and Cooley, he spent about 13 days in the hospital, which is absolutely stunning. And he went home and no complications, and he was alive 15 years later. Pretty remarkable. This is the first series that was published. It was 4 patients. Again, DeBakey, Creech, George Morris, all names that if you came through the Baylor family of aortic surgeons, these are names you would know well. And they did remarkable surgery at that time. This is a first series published in the Annals of Surgery in '56. 4 patients, again, all survivors. The patients did remarkably well. Look at the ischemic times here. I mean, they're long, but they figured it out, and they did well, and we've really stand on the shoulders of people like this who took on tremendous risk and with great bravery and great technical skill to get this off the ground. What's pretty interesting, though, is that the 4 patients from that series and that publication, before it was published, it was presented at the American Surgical Meeting in April of '56, actually in White Sulphur Springs, West Virginia. And if you look at who was discussing this paper, it's really a who's who of CT surgery at the time. John Gibbons, right, the veteran of the heart and lung machine, was leading the discussion on this paper of 4 patients presented by DeBakey. Henry Bonson, one of your former chairs here at UPMC, and my understanding is one of the best technicians ever to come out of the Hopkins program. He was also part of the discussion. Of course, Alfred Blaylock was the president of the ASA at that time. And then Arthur Blakemore and Mike DeBakey were discussing the paper. And pretty remarkable, but what they recognized, and you saw the long times of ischemic times before, was the importance of ischemia. And this is the summary of that paper, and this is their conclusion. The most important consideration in extirpation of aneurysms of this type arises from the potential ischemic damage to vital organs. They knew that this was a problem and it had to get better. 2 methods are available: hypothermia, which we still rely on today, and a temporary shunt. Again, they hadn't figured out partial bypass or anything else or circulatory arrest, but they knew you had to do something to get the blood flow distally. And again, this is 1956. It's pretty remarkable to think that they were able to figure this out after 4 patients. Now, my personal history into aneurysm repair goes back a long way, and this painting is a place that I kind of start. And I know you're wondering, what does this all mean? So this is a painting known as the Four Horsemen of the Apocalypse. It was painted by Victor Vasnetsov in 1887. And it depicted his interpretation of the Apostle John's Revelation 6, describing a scroll in the right hand of God, and he opens the scroll, and out come the 4 horsemen of the apocalypse who have the right to determine how the world will end, the end of days. Death, famine, war, and conquest were the 4 horsemen. They came out of the scroll, and they determined how everything was going to end. Fast forward to 1924, and Grantland Rice was a famous sports writer at the time for the New York Herald Tribune, and he took an offshoot of the 4 horsemen of the apocalypse, and Notre Dame, which is very good at marketing, figured it out even then. Their 1924 football team was undefeated, and actually for the 3 years that their backfield had been in service at Notre Dame, they only lost 2 games and they won 2 national championships. So he came up, along with the Notre Dame marketing people, of the 4 horsemen. And this painting said, basically, if you saw these 4 horsemen coming to you from Notre Dame, your team, it was the end of days. And so it was a very famous picture. So how does this relate to what I knew? Well, when I walked into Houston, and I walked into Joe Caselli's office in July of '96, I saw this picture on the wall. Now, Joe's a Notre Dame grad, and I figured, well, you know, that makes sense. He just has a liking for Notre Dame. But this picture had been bequeathed to him by Stanley Crawford, who is the godfather of all thoracoabdominal surgery, and I really think did more for advancing the cause of thoracic surgery than any surgeon, even Dr. DeBakey and Dr. Cooley. And Crawford had given this picture to Joe as he was retiring, and unfortunately he passed away shortly thereafter. And this picture had been given to Dr. Crawford by the teams, the collaborators that had been worked with him, because so many patients at the Methodist Hospital in Houston had end of days because of neuro, cardiac, renal, and pulmonary complications. And this picture with these complications and organ systems was in the office of Dr. Caselli, and that really got my attention, and it's something that we still think about to this day. And despite all those complications and problems, Dr. Crawford's team persisted. They did many, many, many of these. They were probably one of the only very few places in the world that were doing this at the time, and from their experience, they developed the Crawford classification system, which you see here. Extent 1s going from the left subclavian to the viscerals, 2s involving the entirety of the thoracoabdominal aorta, 3 from about T6 down to the bifurcation, 4s basically being a total abdominal aneurysm, and 5s, this was really put together by Hazem Safi, from the mid-chest down to the visceral vessels. So over a 20-year period, they had a lot of experience. They did operations. They came up with this classification system that we still use today. They also published the first major series on the outcomes of this. This is the famous, we always called it the 1509 paper. It was published in '93. Lars Svensson was the primary author. And these were the results that they got with 1,509 patients undergoing thoracoabdominals. The renal dysfunction is obvious here. Nearly 20% of the patients had some form of renal dysfunction. More than half of this was dialysis. But over a 20-year period, for an extent 1 and extent 2 aneurysms, somewhere between 15 and 30% of patients left the Methodist Hospital in a wheelchair. So although the mortality was fantastic, it's still very competitive even today. 6 to 10% is still pretty good. The renal dysfunction and the neuroinjury stimulated a lot of interest in how we could make this better. And from that experience, they generated this very famous curve that if you're a thoracosurgeon, this never ever leaves your mind. This is the curve that Dr. Crawford's team came up with: unprotected aortic cross-clamp time on the x-axis, the probability of a neurologic injury, a spinal cord injury here on the y-axis. And you could pretty much get away with clamp and sew for about 30 minutes. The risk of a neurologic injury was less than 10% in that setting. But as soon as you got past 30 minutes, and certainly by the time you got to 60 minutes of unprotected clamp time, the risk of a neurologic injury went up exponentially. And so this curve still sits in all of our minds. It's part of the clock that's ticking when you're doing this operation. But this led to a lot of innovation and thought as to how we could make this better. One of the earliest innovations was CSF drainage. And this is one of the few areas in all of cardiothoracic surgery where there is a randomized prospective trial done to try to show whether or not this would be effective at reducing the risk of paraplegia. 145 consecutive AAA repairs, all extent 1s and 2s. They tried to make it as uniform a population as possible. All were performed with partial bypass, moderate hypothermia, low-dose heparin, intercostal reimplantation. They randomized them, kept the drains in for about 48 hours post-op. And what you saw was a 6 to 7-fold reduction in the risk of neurologic injury. The mortality was not statistically significantly different, but the risk of a spinal cord injury was. And from this point forward, CSF drainage sort of became part of the landscape when you're doing thoracoabdominals, particularly extensive ones. I think it is important to have this in. This is our protocol. We have the patients have the drain in with them sitting up before they go to sleep. It's a lot easier to put it in than when they're on their side. We drain the CSF pressure off when the pressure is greater than 12 centimeters of water. We have a self-contained system that sort of auto-drains. But we maximize the drainage at no more than 25 cc's an hour. And this was just, again, learning from experience. We had 2 patients develop subarachnoids from overdrainage because we were trying to get down to this 12 before we realized that 25 or more was too much. So now that's the limit. We don't drain them more than that. We do keep it in place for 72 hours, and we clamp it an hour a day so the patient can get out of bed and get mobilized. Prior to removal, we clamp it for 4 hours and observe their neurostatus and do neuro checks hourly after the drain comes out. Very importantly is rapid insertion in the setting of delayed spinal cord injury. If you have a patient that's walking and doing everything they're supposed to do, and all of a sudden their legs aren't working so well, you get them back to the unit, and you get a drain in fast. And remember, 50% of all the spinal cord injuries are delayed, but the mortality when you have spinal cord injuries is 50% at 1 year. So it's crucial to have this, and I think it should be part of the landscape. Now, once you get the drain in and you're in the operating room again, that curve of spinal cord injury versus cross-clamp time never leaves your mind, and your brain starts spinning. As soon as you put that clamp on, you feel that tick, 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 the clock's ticking, and you got to get moving, and there's a lot of decisions to be made, and it's hard not to forget things, okay? You got to look at, do I open the false lumen? Do I get all the thrombus out now? When do I open the true lumen? Once I've done that, do I fenestrate the septum? How far down do I go? Do I stop? Do I go? How much do I need to take out? The intercostals, what do I do with the intercostals? They're back bleeding in my face. I need to get the bleeding under control, but which ones do I reattach? How do I reattach them? What kind of graft am I going to use? Do I need a short graft, a long graft? Am I going to do separates to the viscerals and renals, or am I going to reimplant them as an island? And finally, how's the patient doing hemodynamically? How is your anesthesia and perfusion colleagues managing the situation? So all this is ongoing while the clock's ticking in your head, and I think you have to be very thoughtful about how you do this operation, and as much preparation as you can do mentally pre-op will help you get better outcomes and help you get through this period of cross-clamping without forgetting things. And I've tried to boil down my thoughts on how to do this best, where, why, when, how, and who, to these basic 4 questions. And the first one that's most important is, can I get proximal control? And if I can, where am I going to get it? This is our algorithm for how we do that. So if you have an extensive calcification in the arch, if you have an aneurysm that's pretty high, or you have a high contained rupture, you're really not going to be able to safely get control. You're going to need circulatory arrest. This is something that we only reach for less than 10% of the time that we do it. Some do it all the time. It's not really been the way we do it. It's not the way they've done it in Houston, but it's useful. And if you're going to be doing thoracos, you're going to have to be comfortable with doing circ arrest from the left chest. But if you can get control, particularly if they have a previous classic elephant trunk or frozen elephant trunk, it's a lot easier to have proximal control. We do an epi-aortic ultrasound. We find these trunks, and then we just clamp the trunk. If it's a frozen, we don't bother opening the aorta. We just put the clamp on the outside. You can clamp these endografts very safely without fracturing things. You just put a padded clamp on it, and you have good control, and you can sew to the bottom of it. If it's a classic, we just open the aorta, drop the pressure down to about 80, open the aorta, grab the trunk with your fingers, and put a clamp on it. It's a crowd pleaser. Everybody loves it. The anesthesiologists go crazy. Everybody thinks it's just, it's one of those things you do a little bit for show. But you get good control, and you don't worry about getting around the aorta, and there's a lot of benefit to not having to get around the aorta, particularly if they've had a total arch before. That's not an easy thing to do. But if they haven't had an elephant trunk and it's a DeBakey 1, and yes, coming from Houston, I do not use the Stanford classification system. I'm not permitted to. DeBakey 1, and we will clamp most of those proximal to the left subclavian. You can do that safely. There is an increased risk of recurrent nerve injury, but no increased risk of stroke, no increased risk of spinal cord injury. On the other hand, if the arch is dilated in and around the subclavian, again, we'll clamp proximal to the left subclavian and won't hesitate to do so even with the DeBakey 3. But a lot of the DeBakey 3s you can clamp distal to the left subclavian, and that's really all you need to do. But you have to really spend time thinking about, how am I going to get proximal control? One of the hardest things to do is to get around the subclavian high in the chest. It does take time. You, again, have to manage this very well because the aneurysms are usually pretty large high in the chest, and your visualization is tough. Once you've gotten control of the subclavian, then you got to get control of the aorta. And in the aortopulmonary window, this is where the soul resides, right? This is a scary place, particularly when you don't see it that well and the aneurysm is big. You got to take down the ligamentum. You got to do it without getting into the bottom of the arch or into the PA. You want to do your best to try to preserve the recurrent nerve. So there's a lot going on in this area, but you got to get proximal control. And then I always try to take my cross clamp out for a test drive. Even if I can get my finger around it, you got to be able to fit a clamp up in there. And we use this padded clamp. You only need to put 2 clicks on this because, again, it minimizes the risk of stroke. It's more than enough to occlude even the thickest septum on a chronic type 1 dissection. It's not a problem. But you really want to make sure that you can get around the aorta, around the subclavian, and that clamp is absolutely going to be secure in this place, because without proximal control, you got nothing, all right? Now, you have proximal control, or you're thinking about now as you're planning, do I need circulatory support, and why do I need it, and if I'm going to have it, how do I do it? And I think the why is evident from this paper. This is looking at extensive aneurysms, and what you see is that in the setting of left heart bypass on univariate analysis, there's a trend towards a reduction in spinal cord injury on extensive aneurysms. But here you see on multivariable analysis a definite relationship, a significant relationship between unprotected ischemic time and the incidence of immediate and delayed neurologic injury. Left heart bypass for extensive aneurysms markedly reduces the incidence of spinal cord injury, and I really think it should be something that you think about doing all the time, especially when you're doing extent 1s and 2s. Not so much for 3s, 4s, and 5s, but certainly for 1s and 2s. Again, how do you do it? This is what we do. We put a catheter into the left inferior pulmonary vein. We usually return blood into the descending thoracic aorta. We will only go to the femoral artery in the setting of an acute type 3 dissection. We rarely go into the femoral artery for anything other than that. We give 100 per kilo of heparin. We passively cool the patient down to about 33, 32. We don't go lower than that because the arrhythmias and the cardiac function become an issue. And we don't flow at more than 3.5 liters a minute. We do not monitor distal pressures. That's unnecessary. All you really want to do is keep proximal hemodynamics normal. And then you got to have a good rapid infusion system to return the shed blood from the intercostals, particularly in the setting of a dissection where most of them are still patent and the back bleeding can be pretty profuse. Most degenerative aneurysms, a lot of them are thrombosed. You don't have to worry about it so much. But this gives you the time to ligate those intercostals. It gives you time to think and to stay calm and to move through the process very well. So I think this is a good system. Now, once we have the proximal anastomosis done, we now turn the pump off. We open the aorta all the way down to the bifurcation. We use the pump to take blood, oxygenated blood, out of the system and put it into the viscerals through perfusion occlusion catheters. These are 9 to 12 French. You can flow at about 500 to 800 cc's a minute through these. And then for the kidneys, we use cold renal perfusion instead of blood, because this too has been shown in a randomized trial to reduce the incidence of acute kidney injury following this operation. Once we do all these things and get this going, we then reattach intercostals, usually in that region between T8 and T12 where the magical artery of Adamkiewicz is supposed to live. There's really no great imaging modalities that help you find this preoperatively. I think that mostly misleads you. But in general, you want to put about 2 sets in. You don't want to put too much aorta because then you set yourself up for an aneurysm, a patch aneurysm down the line. Once we do that, we then move the clamp below this and do the distal. Now from that point forward, that's as good a blood flow as that patient's going to have to their spinal cord for the rest of their life. So this has really reduced the injury of the neurologic injury rates, and then we do the viscerals and renals separately after that. This too has been something that we've adopted over time, and that's reduced the incidence of patch aneurysms and pseudoaneurysms, especially in the connective tissue patient when you're doing these big patches around the viscerals and the renals. It can sometimes be unwieldy. So do the separates. I think it works better short and long term. Should you reattach the intercostals? How are you going to do it? Why are you going to do it? And when in the operation are you going to do it? Well, again, go back to this data that shows the why. The why is because it works. Again, there's a marked reduction in the incidence of spinal cord injury in patients who have reattachment of intercostals. And on multivariable analysis, again, a reduction in permanent paraplegia and delayed incidence of spinal cord ischemia in patients who've had intercostal reimplantation. Again, looking at extensive aneurysms, not 3s, 4s, and 5s, 1s and 2s. How you do it, there's a lot of ways to do it. Again, this is our way of doing it. You saw the illustration. This is a video from us reattaching a couple of sets in the middle on this insert here. But some people choose to do it after the whole thing's finished. They might put a graft onto those intercostals. They might use one of these little U-grafts to the intercostals, or they might detach the intercostals and use a side biter and just reattach them directly. Any one of these techniques works, so long as you do it. And it really does, I think, not so much for the immediate paraplegia, although statistically speaking it does, but I'll tell you, when the patient's hypotensive, hypoxic, going into AFib, something like that post-op, having a couple of extra cc's of blood per minute or hour going into your spinal cord circulation, it really helps. And I think that's really where it benefits, and that's why I think you should be doing this on extensive aneurysms. This is the finished product, and you've all seen it. The proximal anastomosis is here. Our intercostals are reattached here. The visceral patch here. The left renal is usually displaced, so even if you do an island, a lot of times you have to graft the left renal separately. But the finished product is pretty impressive, and it's something, if you don't see it all the time, it really catches your attention. And then not for nothing, you've done a great operation. Now you got to get them up to the unit, and you got to have a team that's going to work with you. So who's going to be with you, and what do they need to do? Okay, so there's no I in the word team. These 5 things you're going to do in the OR, right? CSF drainage, moderate hypothermia, intercostals, left heart bypass. And I don't want to exclude speed. Of all those things we saw, right, that curve, you're shifting it to the right, but you're not getting rid of it. Okay, so even under the best of circumstances, and I was told that Dr. Crawford once did an aneurysm with a 12-minute cross-clamp time and had a paralyzed patient. And I've never forgotten that. And if you're doing thoracosurgery, this needs to still be part of your thinking. You can't dawdle. You don't have all day. At some point, you got to get the clamp off and get moving. But once you get through this whole period, you need to get up to the ICU, and you have to have a team helping you work on maintaining a mean arterial pressure that's pretty high, certainly much higher than you would expect for most cardiac cases. And you want to optimize the delivery of oxygen. That's the key to your end organ survival. So it's not just the mean arterial pressure, it's the everything. We want to maximize cardiac output, stroke volume, heart rate. We look at heart rate. Importantly, most of the time these patients are not paced, but we will pace them in the operating room atrially and in the ICU, particularly if they have AI. In patients who've had a previous type 1 repair, if they had a spared root, sometimes they have AI. And if it's more than mild, it's going to be a problem when you put that cross clamp on up high. And you're going to be happy that you pace them at a faster rate so they don't distend and arrest. So we will continue to do that. We want to be mindful of rhythm. And if they start having APCs and VPCs, load them up with amiodarone. Try to avoid AFib, because AFib leads to a drop in cardiac output, drop in blood pressure, delayed paraplegia. So we treat rhythm disturbances aggressively. We want to use Swan Gants on everybody. We don't believe in trying to do these and try to be too smart and get them upstairs with a CVP line. At least I'm not smart enough to figure that out. I need to know their preload. I need to know their afterload. And I will not hesitate to add contractility. We need to maximize cardiac output. And then finally, again, it's the everything. We also want to enhance content of oxygen. We keep their hemoglobins greater than 10. This is one of our recommendations in our guideline statement from November of 22. We usually don't transfuse for anybody, say, less than 8 or 7.5 in a cardiac patient. For a thoraco patient, we want their hemoglobins greater than 10. Again, you're maximizing oxygen delivery. And then finally, if you get them through the first 3 days, everything's okay. You can't let your guard down. You have to continue to round with your ICU team as we do every day. We're looking at everything. It's the everything. There's nothing that's not important in a thoraco patient, because any one of deviations off of these things can lead to a major problem. Renal failure, pneumonias, we've seen it all, as you have too, but it's really important to have a checklist and to go through it on a daily basis. Now, over the last 20-some years, we've done about 1,100 of these. More than 50% of the ones we've done have been extent 1s and 2s. Most of them have been in an elective setting, but about a third of all of our patients are emergent, meaning within 24 hours of presentation. And 13% of our patients were ruptured. Mostly large aneurysms, almost 7 centimeters in diameter. A lot of these were followed for a long time for reasons that are unclear. We use circulatory assist in about 50% of the time. Most of it's LA to distal aortic. Again, use the femoral artery about 12% of the time. Circulatory arrest, less than 10%, 7% of the time. Again, when you can't get proximal control and it's just an absolute mess high in the chest, put them on fem-fem, cool them down, and things seem to stabilize pretty well. We are heavily invested in CSF drainage. The only ones that don't get it are the ruptures who are unstable. We don't put it in. We don't have the time to put it in before, but we will put it in after. So once we fix them and they're closed, we roll them back on their side, we put a drain in and take them up to the unit. So we're big believers in it. A lot of concomitant procedures get done with these patients. Again, all the 1s and 2s, we try to implant at least one set of intercostals. Most of the time, it's 2 or 3 sets, as you can see here. And we're very, very gratified with the results we've got using this technique. Our mortality is 4.9% for all comers. In the elective setting, it's about 2.1%. We believe a lot of this is good surgery and attention to hemostasis. Only 2.5% of the patients have ever gone back for bleeding. And when they do bleed post-op, they're very unstable. So you really have to do what you can do upstairs, before you go upstairs to get them dry. Spinal cord injury rate, 2.8% overall. And again, half of those or a third of those are delayed injuries. But fortunately, only 1.5% were 0.6% were permanent paraplegia. The risk of renal complications is about 8%, with about 4.5% or so being chronic dialysis. 4.6% still had dialysis at discharge. So it's still a work in progress, and there's a lot of opportunity for improvement. Respiratory complications still haunt us. 6% of patients require a tracheostomy at some point post-op. Recurrent nerve injuries, thankfully, very limited. This is a bigger deal than you think. You think, well, I just want to get proximal control. It doesn't matter. Well, it kind of does matter, because when you don't have one of these that work, you end up with more of this. And so you got to have a good recurrent nerve so that they can cough and they can clear their secretions post-op, and then importantly, they can swallow as well. We keep the drain in for 3 days. We then clamp it and take it out and do our protocol, and that seems to work well for us. With open surgery in our hands, the long-term survival has been pretty good. At 10 years, it's greater than 75%, and we're very pleased with that. And it's a very durable operation. Less than 4% of the patients have required reintervention at 5 years, or even at 10 years, you see 3.4%. So it's a very durable solution to this problem, but it does require a lot of attention. So when I talked to Dr. Sultan earlier, he said, well, how can you take this and translate it to the newer surgeons and younger surgeons, because it's a pretty complex thing. Endovascular repair is becoming more common, and how do we get the experience to do this? And tried to think about this a little bit, and I think one of the most important things is understanding that this isn't going away, right? The technology is going to get better, the grafts are getting better, the techniques of putting them in and monitoring them and how you do them are getting better. But I think one of the things we really have to start with is we have to continue to have a discourse with our vascular surgery colleagues and anybody else that's doing endovascular repair in this area. Because I think the results have a long way to go, and I'd like to see a little bit more transparent discourse between the vascular surgeons and the CT surgeons who are doing these. Okay? Even with a single stage, and most of these, remember, are extent 3s and 4s that are being done, the mortality is still about 10%, and more extensive ones where they stage them in 2 stages, it's still, again, about 9%. Now, certainly there are going to be centers of excellence that do better than that, but that holds true for open surgery too. The spinal cord injury rates are not low. And so, yes, endovascular technology is progressing, but we got to make sure that we have apples to apples comparisons when we're talking about it. You can't compare series with 80% extent 4s to series with 70% extent 1s and 2s and say, there it is, endovascular is better, or open surgery is better. You got to be transparent about what you're comparing, right? We've seen this with our structural heart colleagues, where apples and watermelons are being compared. And we've allowed that bus to leave the station, and it's going to be hard to get it back in. I think we just have to be honest about what we're doing. And this is a very, very experienced group of vascular surgeons looking at data from the SVS Quality Initiative, and their conclusion was open surgical repair remains the gold standard for the treatment. Now, I think that paradigm is going to continue to shift over time, so we have to stay involved. For the younger surgeons, just keep in mind, nothing can replace good surgery if you're going to take these operations on. It's very important to have good surgical technique. It's really, really important to have good technique, because hemostatic suture lines are the key to getting this operation done well. You cannot have bleeding in the OR or upstairs. They're just too unstable. It's high-pressure suture lines, a lot of bleeding. You're running their means high. And a lot of times, it's very difficult to access some of these suture lines without disrupting things further. So your surgical technique is something you have to work on from your very first days in training. And even as a junior faculty member, you just got to get better and better and better with your technique because you have to control the bleeding. Right? Everybody says, oh, it's a coagulopathy. I hear the same thing with hypothermia for the arch. Oh, it's a coagulopathy. No, it's not a coagulopathy. It's a proline deficiency. All right? That's what I call it. All right? You haven't put enough stitches in. You haven't done it well enough. You've got to get better at it. And that's our job as the mentors for the younger faculty and the residents. We have to stay on them about it. And it really starts here with surgical technique. This is an illustration of the pathway that needles take through this to close this cleft. Okay, and this is something you got to work on from day one. If you take a nice path and you follow the curve of the needle, you get a nice circular hole which matches up well with the diameter of the suture. Needle hole bleeding is not a major issue. Really important. But when you skive it, as in 2 or 3 here, you get this oval. The oval's bigger than the suture. It starts bleeding like crazy. And everyone goes, see, it's a coagulopathy. No, it's not. It's a proline deficiency, and it's your technique. So it's our job as mentors in a training program to really work on getting the residents, getting the junior faculty to work on their technique because it really is important. The first thing you got to do is get them out of the OR with a hemostatic operation. Without that, all that stuff I showed you in the last 30 slides, meaningless. Nothing's going to work if you don't do this well. The next thing I think that's very, very important is Dr. Spencer is saying you never get over bad training. And I do think that's on us. That's on the faculty. We have to make a commitment to do the training. And I know you have I-6s here. We don't have I-6s. We just have 5 and 2s. So you still have to take the fellows that come through 5-year general surgery training programs and make sure they're doing this well. And I think one of the reasons that it's so important is because vascular surgery training in the general surgery programs is not a lot of open surgery. They get really good with wires and catheters. I mean, our residents are really good at it, and certainly the junior attendings are really good at it. But they don't get a lot of experience sewing blood vessels. And so we just have to put the time in to get this right. But I think Dr. Spencer was right. You never get over bad training, and I don't forget that either. Now, the other thing you got to do is you got to plan. These operations require a lot of thought. You saw when that clamp goes on, I really think that tick, 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 there's a lot going on. There's bleeding, there's anesthesia, perfusion, you got a lot going on. You got to plan your operation, you got to think about it. Abraham and I were talking about it last night. You know, you don't sleep the night before an extent 2. You just don't. There's so much going to happen during that operation. You're thinking of every contingency. And as Sir Winston Churchill said, if you fail to plan, you're planning to fail. Have these things going on in your head. And then as you're working through the operation, as Kipling said, keep your head when all about you are losing theirs, and more importantly, blaming it on you, right? Everything else could be going on in the room. You got to keep your cool, you got to stay focused, and that comes from practice, 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 and practice. Because ultimately, if you don't have protocols, if you don't practice enough and you don't persevere, you're going to fail. And as that great philosopher, Iron Mike Tyson, said, everyone's got a plan till they get punched in the face. And a thoraco is like getting punched in the face. There's always something coming that you didn't see, that uppercut, that cross. Something's going to happen that distracts you and takes you off your protocol. Some of it you're going to be able to fix. Some of it you're going to have to manage in a very aggressive way, but in a thoughtful way, and you got to stay calm. Okay, so be prepared because you're going to get punched in the face at some point if you do a thoraco. It might be in the ICU where someone's doing really well. And the next thing you know, they're telling you they're not moving their legs or they're weak in their legs. Again, you have to move quickly. Protocols, practice. You've done it again and again and again, and you just got to persevere. It's really hard to take these on if you're not going to persevere because you're going to have some bumps in the road. So in conclusion, I really think perioperative planning is crucial to the success of this operation. Do not fail to plan. Technical prowess is critical. You got to have good surgical technique, and you got to get them out of the OR hemostatically, and have a plan because there's going to be some bumps in the road. You're going to get punched in the face. It's just a matter of when. Never miss an opportunity to get better. And I was really happy to sit in on your M&M earlier today and hear people being passionate about correcting what you could correct and being committed to your perioperative care. Okay? Radical transparency is a concept put forth by Ray Dalio, who runs one of the biggest hedge funds in the world, Bridgewater Associates. And basically his concept in that hedge fund is radical transparency. Anything can be said by anybody to anybody at any time, and you're not allowed to take offense. Well, that doesn't work too well in the medical world, right? That's going to get you in HR. But nonetheless, I do think transparent discussion amongst professionals has to occur. We have to own it, right? I heard Mr. Tomlin say that the other night. I own it. I carry that baggage. Right? I've heard them all. But you have to own the complications. You have to get better because there's perioperative care for thoracos that's very important to the ultimate outcome. We have to continue to innovate. We have to get better at our organ protection from the spinal cord to the kidneys to the lungs to the heart if we're going to ever reduce the incidence of adverse events and mortality. And this goes the same for endovascular techniques. And then finally, you got to really put a good team together. Your anesthesiologists, your critical care teams, they have to be important parts of your team, and you have to communicate. So I really thank you for the opportunity to present this morning. I have no idea whether I ran over on my time. I apologize if I did, but thank you for your attention.
Thank you so much. That was outstanding, and not just a talk, but incredible results that I think are just so hard to replicate. Today's a little bit up for questions.
Hey, thanks so much for this great work. Oftentimes I tell the residents that some of the fastest surgeons, such as Joe Caselli, Doug Cooley, and operate, they don't look fast when they operate. You mentioned speed is one of the big technical challenges of operation. Can you comment on how you gain speed without actually appearing to be fast in an operating room? And specifically, how can residents take that on? So occasionally, it's difficult to understand a concept. So I want to get your comment on that.
Yeah, I think it's a great question simply because I think speed just comes with experience. And you're right, it's more about efficiency than it is your hands moving at 100 miles an hour. And I think that doing it thoughtfully, but again, if you practice it right and you do it right when you're learning and you're training and as a junior faculty, you're not going to be as fast as the senior members of the department when you're first starting. You just don't have enough experience. But if you do it right and you minimize your mistakes so you don't have to double back and you don't have to fix holes or tears, you're saving a lot of time just doing that. And so, one of the most efficient, fastest surgeons I've ever trained with was Jan Quagabor, who I know Victor would know. Jan never looked like he was moving fast. He was one of the best congenital heart surgeons I ever saw. And everything was, and next thing you know, it was over. The operation was done. And it was just because he was moving along. I always told him it's because he was sewing, a 2-millimeter vessel, and it doesn't take that many stitches to get around. And we're sewing a big one. But the truth is, he was just an amazing technician. But he was never moving fast, but he was very efficient. And I think, that needle hole bleeding, you saw my little illustration of the size of the needle holes, right? Those needle holes are very meaningful in aneurysm surgery, period, just because it's high pressure, high flow. Bleeding can happen fast through needle holes. I mean, it's amazing. Think about just doing an ascending, and sometimes you're sewing to a Marfan or Loeys Dietz aorta. It bleeds like hell, right? And I thought I did it perfectly. So just more, technical. Pay attention to your technique, perfect it as best as you can, and just never feel that you've reached a pinnacle. I still try to get better every day, and just try to do what I did better than I did the day before. Just really focus on technique.
Thank you.
Thank you. That was a great talk. Actually, that picture I think we should give out to all the residents. That was my favorite picture of the slideshow. But with the needle, because it is so important, and the tissue you're sewing too. Could you just comment on imaging in your planning? We show a lot on that, and I think that's and has that changed over time?
Yeah, I mean, obviously the imaging from when I trained to now is, it's like driving a Aston Martin compared to, some beat up Ford Pinto. It's vastly different. 3D reconstruction has made an incredible difference in in what we do. And that's where you can sit and stare at it for a while in your office by yourself and come up with a plan. I can think about how I'm going to clamp. I'm going to think about where are my trouble spots. I can think about how am I going to handle the viscerals and the renals. And then also the imaging helps me plan. Am I going to have to endorectomize something? Are we going to stent something? So it gives you so much more detail than you ever had in the past, and it really does allow you to plan a lot better. So the roadmap that you're going to have to do these operations currently is vastly different. And we learned a lot of that, too, from our vascular surgery colleagues who've been looking at images on the branch vessels and things like that a lot more than we had, unless you've been doing this for 30 years. And so I think we can learn a lot from that, too, because obviously if you're going to do an endovascular thoraco, there's a ton of planning that goes with that. And 3D reconstruction, you have to be facile with doing that and being able to use the software so you can get a pretty good look at things. So I think these are all things that are very important. The other thing I would say, too, from the imaging, don't get distracted in the pelvis. You're going to see big iliacs, particularly in people with Loeys-Dietz, Ehlers-Danlos, and Marfan's, particularly chronic dissections. You don't have to fix all those iliacs because that really makes it much more complicated. You get down deep in the pelvis, that's not a fun place to be from somewhere on the left chest over here, especially the right pelvis. And you can get yourself in a world of trouble down there. And so that's a great place where it's sort of, hybrid's the wrong word, but it's okay, even in connective tissues, to stent the iliacs or live to fight another day. So it's easy to get distracted by the imaging, I think, at times, but in general, it's very, very helpful and vastly different.
Thanks so much for the really remarkable talk. I was wondering if you could elaborate a little bit more on areas that require more research and innovation in open surgery. We hear a lot about endovascular techniques and things like that, but it does seem like there's going to be a role for open surgery for the foreseeable future. I'm just wondering, particularly for our residents that are interested in research and pursuing things in the lab, where do you see the key areas of research and innovation in this field?
I still think there's a lot of opportunity for improvement in spinal cord ischemia, for sure, and particularly in end organ protection and mostly renal. I mean, those two things that you saw going back to the 50s and then subsequently the randomized trials on CSF drainage, the randomized trials on renal protection, we need to continue to innovate in those areas. There's an ongoing trial on preoperative intercostal occlusion. Mostly it's European. Christian Etz is running that trial. They've had a lot of trouble enrolling, quite frankly. So it's laudable that they're trying to do this, but the truth is there are some patients who have incurred injuries just from intercostal, preoperative intercostal occlusion, and so that's, people get a little bit nervous about that. We have to do a little bit better job, I think, with imaging. Certainly CTAs, as you were explaining about the imaging, can give you a little bit better idea of where the important spinal cord blood supply is in that T8 to T12 region. We haven't really gotten there yet, though, in really understanding what's really the important one. So the truth is we're still relying on, if it's big and it's not back bleeding, it should be reattached. I mean, that's an eyeball thing and an experience thing. And you know what? Sometimes you're wrong. And that's really disappointing. But thankfully, most of the time you're right, because as you saw, the incidence of immediate paralysis is pretty low. And so we think that by having high mean arterial pressure, getting the full complexity of the aneurysm repaired, and then working on your viscerals and renals, it cuts down on your cross-clamp time, it cuts down on your unprotected ischemic time. Those are things that are going to be bigger and bigger. The one thing I don't do, and I know that Caselli doesn't do it either, is neuromonitoring. I don't know what to make of motor evoked or somatosensory evoked potentials, except to say that you're already nervous, you're already moving along as fast as you can, you're trying to get the clamp off, and when that MEP goes, woof, everybody starts freaking out, screaming and yelling at a higher pace, and it doesn't help. So I don't do it. I don't want to know what the MEPs are doing. I don't want to know what the somatosensory evoked potentials look like, because I'm doing everything I can do as fast as I can do it. So for me, you know, it's an area of investigation. People do rely on it, but I just haven't found it to be helpful. And then renal protection is just something, you know, it's a little bit of a black box. Sometimes you do a fast operation and they're not making any urine when you're done, and you don't know why. You used cold renal protection. Probably would be better for us to have a better understanding of what's going on at the actual cellular level in the kidneys before we start. But we really haven't gotten there yet. But I think those two areas are still the major areas of problems with this operation.
Thanks so much.
Yes.
Thanks again. It's great to hear you talk, and it's amazing, you know, the results you've got. A lot of us look back at Stanley Crawford's work and think, you know, most people's results have not improved from that. But it's amazing to see everything that you've done there at Cornell. My question, I'm interested in the emergent cases that you did. So, what are kind of the common circumstances for you to do an emergent situation, and when are they amenable to T-bar and endovascular stuff? Is this mostly, you know, extent 2? Is it rupture? Is this acute dissections that rupture? Or what has been, you know, some of the more common circumstances for your emergent situations?
So we've done a lot of ruptures, but I think everything's going to depend on what your institutional expertise is and on availability of those environments that you would do such a case. So yes, people talk about stenting ruptures. And I think if that's what you do and you know how to do it well, that's what you should do. Get the hole sealed. And we can talk about another operation, an open operation down the line. So if you have really good endovascular surgeons and not so much experience doing open surgery, I'm highly supportive of the idea of temporizing with an endograft. And I think the same happens even for mycotics, right? Mycotics are definitely something that long term you want to take a little bit more of an aggressive traditional approach to debridement and getting the infected source out. But if you're really good at endovascular, plug the hole and live to fight another day. For us, ruptures still come in from all over the area. We're sort of a regional referral base for that. So a lot of what we do is still ruptures. You saw 13% of our cases are ruptures. And we've done about 80 acute type Bs. We just did one last Thursday, but it was a 28-year-old postpartum acute type B with a rupture in the setting of Loeys-Dietz. And the aorta was 20 millimeters. Hard to stent that, right? So for us, thankfully we have ORs available, we have great anesthesia, we have great critical care. We can get somebody like that to the OR quick and do that kind of operation and do it with repeatedly good results. But it's taken us 27 years to get there. And so, I think probably if you say what was an important decision for me starting this program, for my first 2 years from 97 to 99, I was the only surgeon at Cornell doing this. There was no plan B. There was no backup. There was no cavalry coming. So I didn't take on an extent 2 for 2 years. Like you were saying about getting speed and getting faster and getting more experience. I did 1s, 3s, 4s, and 5s, but I didn't touch a 2 for 2 years because I couldn't afford, well, number one, I didn't think I was ready to do it. Number two, I didn't want to have a paraplegic patient sitting in the unit where everybody goes, it really shouldn't be doing this. That happens, right? The word kind of goes around. So we've taken it on. We've gotten more aggressive with some of these things, but it's a stepwise progression in getting to these kinds of patients. Yes, sir.
Do you see the skills of open growth abdominal surgery and endovascular complex repairs existing in one person? And if not, how do you best manage the skills in separate divisions or in separate specialties and coming up with the best treatment for each patient?
Yeah, it's a great question, and it's certainly one that we have not been able to manage well in New York. The first question I think is easier for me to answer, but I will put it out there that I have an extreme bias. I don't think that you can be a fantastic endovascular thoracosurgeon and be a fantastic open thoracosurgeon. You know, I think we do a pretty good job with these, but I don't do all the fancy stuff with wires, and I don't in any way profess to be good at that. Our vascular colleagues are much better at that than us. And so I think they do that very well. I would love to see an environment where we take a patient who has a problem and we truly sit down and say, this patient is best served by operation X. And who should be doing that operation? That's a tougher one to overcome. It's the silo effect. And breaking down the silos would be great. But I do think that it will take some discussion and some consideration on really what is best for the patient and not so much what's best for your division or your department or whatever it may be. And those are hard conversations. We have not overcome that yet in New York. We just haven't. We've struggled with that. So I don't have a solution to how to make it work. Clearly in 27 years I haven't been able to make it work. But I do think there's a role for that, and I think if you have an administrative structure that can kind of put down the word and it's coming off the mountain and that's how it's going to be, I think that would go a long way towards getting things organized properly for the patients. Hey, Vic.
I'm just wondering, can you, I think for the residents and young attendings, obviously you came into your Cornell and you build a new program. And I think it'll be useful maybe if you can comment on what did it take, what do you think was important for you to succeed coming into a very competitive environment where you're sort of new kid in town, building a very complicated program. Obviously you succeeded. And what were, you think, the important facts that allow you to succeed, starting, from interactions,
Yeah.
skill set? What's important for a young attending, for somebody who's graduating to succeed in a difficult environment?
Yeah, I mean, I think the number one thing is really support from the senior members of a department or a group that you join in private practice. Just because you finish training doesn't mean you're ready to do even a complex cabbage on your own without the occasional bump in the road, and your partners or your chair or your vice chair have to be there to really support you through the early times. When I finished Houston, I was being recruited back here. And there was a new program, it still exists, right, at Beaver County Medical Center. And it was brand new, and they wanted me to go out there to be the chief. And I thought, well, any place dumb enough to hire me as a new grad to go be a chief somewhere by myself, I'm not doing that. And so I think when and we see it in private practice actually more than in an academic setting where, there's a lot of people around here. You guys have a lot of great surgeons, and on any given day, somebody's available to go down and help out and kind of get you out of a situation. That doesn't exist everywhere, and I think, unfortunately, for the younger surgeons, it doesn't take much in the current era with the level of transparency we have and a focus on immediate outcomes. You don't have as much of a learning curve as we did. We had a lot more time to get that skill set, and now you have to get off the ground running, and you got to do it great from day one. And so it takes a village there, right? You need a team that's really going to back you up and support you, and I think the senior members of a department or a group have to take that on if you're going to bring on junior faculty. I just think you can't leave them out there on their own. There's just too many rattlesnakes under the rocks.
Can you comment on the use of any bioglue or any to help you achieve hemostasis?
I don't use much of it. I certainly don't put it into the layers between a dissection on a type A. I think there are probably some needle hole bleeding situations that it's probably pretty good for. So say, a Loeys-Dietz or an Ehlers-Danlos, which is really the worst-case scenario, particularly for an acute dissection, I'll use finer sutures, and then before I take the clamp off, I might glue it then. And that helps the needle hole bleeding that I was describing earlier. So I do think there's a role for it there. I think you have to be pretty careful, though, about just slopping it on when it's really thin liquid, and because there is data that it gets through the holes inside, and then you can't figure out why they've had multifocal strokes upstairs. Well, there's a lot of reasons for it, but you don't really know that it's not the glue getting through the holes and then becoming part of the problem from the inside. So I use it sparingly. I'll say one of the things I've done is when I'm using BioGlue or some of the other topicals, if it's really liquid, I just put it up into the dispenser and I kind of let it sit there until it gets thick. And then I put it on almost like paste so that I know it's not, the chances of it seeping through a suture line or a needle hole are a lot less. That's just how I've been doing it. And so far it's worked, but I don't use a lot of it, I have to say. Do you use a lot of it?
I mean, I would say a couple times a year when I think it's usually prophylactically.
Right.
When, in the middle of the operating, like, okay, there's no way I'm going to be able to get a better result if I have to recross them. I would say I count on one hand number of times a year we use. The third time, fourth time redo, just before we see the
Right. It's a proline deficiency. Right.
last question.
Thank you for your talk. I've got one question. With the proliferation of endovascular surgery, did you notice any decrease in the open volumes for now and over the past 10, 15 years?
Our volume hasn't really dropped off, but what we're seeing is a regional referral base for complex things that can't really be stented. So, bad landing zones, previous TVAR, mycotics, chronic type 3s, chronic type 1s in particular. Our volume hasn't dropped off for that, but that's really what we're seeing. So the degenerative aneurysms, we don't see many of those anymore unless they have really bad landing zones. I think the degeneratives are going to continue to go away. I do. I don't think that's going to be where we make our nut with open surgery. It's going to continue to be chronic dissections. And I think, this is where I just think that we have to have really open discourse about what is the patient population that is best served by endo, best served by open, and how do we get there? And so if we're really talking about the same populations, compare extent 1s to 1s, compare 4s to 4s, I think that we'll be able to sort it out what's best for the patient. I really do. Because I think endotechnology is just getting better and better. The skills are better. The devices themselves are better. Preoperative planning, imaging is better. So you can really do a pretty good job early, but then also be very transparent about the late results, right? Reinterventions are high. That's part of the deal. Some of those reinterventions are not so easy, and the solutions are not very good. And then we get down a pathway that can really be a problem. And the same goes for open surgery too, right? There are people you probably shouldn't touch. And yet sometimes we do, and that's not good either. So I just think it's really going to take just continued open discourse about really what are the outcomes for each patient population that we're looking at, and make sure that they're comparing apples to apples.
Well, thank you so much.
Thank you.